Now that you've screened patients for increased fall risk, assess for ways to optimize therapy to create your patient care plan. Medication review and management is one of the most effective tools in reducing fall risk. Begin by gathering information on all your patient's medications. If your patient is on an opioid or benzodiazepine, check prescription monitoring data for medications from all prescribers.
Pharmacists are really busy people, but spending that time with patients or their medication records and just quickly reviewing the records for fall risk is really important. In the pharmacy setting, a few minutes can go a long ways in those medication reviews.
For a medication review, we include anything the patient is taking. It could be prescription or non-prescription. And for non-prescription medications, we're including over-the-counter medications, OTCs, and even herbal supplements.
In older adults, some medications may need to be tapered or changed. Generally, stop medications when possible, switch to safer alternatives, and reduce medications to the lowest effective dose. While it's often hard to stop medications in older adults, optimizing medications can improve patient safety.
We want to identify those potentially inappropriate medications and then work with the patient to find out what they're using it for and if it's something they absolutely need to be on, and how can we work with the other providers, prescribers in the area to see if we can reduce the dose or actually get them off the medication if that's appropriate.
Consider medications without a current indication. Look for duplicate prescriptions and identify any medication with risks that outweigh benefits. Some medications require tapering to safely discontinue use, such as benzodiazepines. Tapering is recommended for medications like antidepressants and opioids, where gradually reducing the dose is better tolerated.
I approach tapering a variety of different ways, looking at the half-life to see how long the medication is staying in the patient's system, but then also importantly looking at the kidney function and the liver function of the patient.
In general, I think most patients can taper off medications with a 10 to 25% dose reduction every 2 to 4 weeks, depending on the drug. So that would be my general approach. And then I'll taper that approach depending on, again, how long the patient's been taking the medication or what the potential risks are of stopping the medication quicker.
When tapering, working with the patient is key to success.
I also want to see if the patient's going to buy in to the tapering at all, because we really need the patient to be able to follow a schedule and to be able to taper off that medication successfully.
For medications with potentially harmful side effects, consider switching to an alternative with a better safety profile. For instance, for a patient taking diphenhydramine for allergies, consider switching to a product that does not increase drowsiness or dizziness, such as nasal saline or a second-generation antihistamine. Some suggested alternatives for common conditions are presented in the supplement to the updated Beers criteria. Finally, for any needed medication, periodically consider reducing the dose to find the lowest effective dosage. Dosage reduction is important because, as patients age, pharmacokinetics and pharmacodynamics can change. For example, an 85-year-old taking antihypertensive medication for decades may now be experiencing orthostatic hypotension and need a lower dose. Additionally, older adults may experience new and harmful side effects from medications. For example, an acute illness can cause new side effects like dizziness, balance problems, or confusion. As the patient ages, consider whether the benefits of aggressively controlling blood pressure or blood sugar outweigh the potential harms.
We want to make sure that we use the minimum dose and the minimum number of medications that's going to give them a therapeutic outcome and not put them at risk of an adverse drug reaction.
When optimizing therapy, include non-pharmacologic recommendations to manage common symptoms or conditions like sleep problems, pain, and anxiety.
Insomnia is a really tough condition to manage for patients because medications can cause so many side effects, but there are non-pharmacologic options that could replace the patient's pharmacotherapy. For example, cognitive behavioral therapy is a really evidence-based approach to helping the patient sleep naturally and to get good restful sleep.
For sleep hygiene tips, click on About Sleep at www.cdc.gov/sleep.
One of the non-pharmacologic alternatives for pain would be physical therapy. I think physical therapists are able to work with patients who have pain and allow them to either decrease their pain through certain exercises or even become stronger through those exercises.
It is important to focus on progress toward functional goals when managing chronic pain. Effective non-pharmacologic options include physical treatments provided by a physical therapist, such as exercise therapy and weight loss, and behavioral treatment provided by a mental health or behavioral health specialist, such as cognitive behavioral therapy. For more information on alternatives to opioid therapy, refer to CDC's non-opioid treatments for chronic pain. See www.cdc.gov/drug overdose for the prescribing guideline and additional resources.
Anxiety is really a condition that often can be treated without pharmacologic treatment. Patients will often benefit from breathing exercises, for example, and if they really do have severe anxiety, psychotherapy is going to be helpful for them, and often in combination with low-dose pharmacologic therapy if it's really severe.
No matter what your practice setting or how you review medications, the goals are the same: to optimize therapy, improve patient safety, and optimize health outcomes. Use the JCPP process to evaluate the appropriateness of all medications, consult clinical resources and recent guidelines when necessary, and use your clinical judgment when making recommendations to prescribers.
I would advise pharmacists to be proactive when they're working with older patients and concerns about fall risk. I would make sure that they understand that there's certain questions they need to be asking the patient. There are tools out there that they can be using that can help them to assess the patient's fall risk, making sure they're very aware of the literature, reading the most current information out there regarding potentially inappropriate medications, making sure they're familiar with that, making sure they always have options if they're going to make a recommendation to discontinue therapy, so that we're not just identifying a problem and not giving a recommendation to the prescriber, making sure that patients are educated, making sure that we have educational materials that are really available to the patient, and just making sure that we work collaboratively with the patient, the physician, and the pharmacy all working all in unison.
Take a moment to review a patient case scenario. This is the first of 3 activities in the training. In each activity, you will act as the pharmacist and will have the opportunity to screen, assess, and intervene in a different pharmacy setting. You can download and print the full case from the resources section if you like. In each of the activities, you will also have access to the patient's medical history, medication list, and lab results for the knowledge checks. First, let's meet our patient, Mr. Adams. Mr. Adams is a 72-year-old African-American male who comes to the emergency department. He reports swelling in his legs, needs 3 to 4 pillows to sleep, has gained 5 pounds over the past 2 days, and is having difficulty walking 2 blocks to the grocery store without becoming short of breath. He reports having sleep problems, worrying more, and feeling down. To help him sleep, he has been taking clonazepam 1 milligram nightly for the past year and reports forgetting conversations he has in the early morning. The emergency department staff concludes that he is experiencing a congestive heart failure exacerbation. He is admitted to the hospital for diuresis and reassessment of his heart failure. Mr. Adams' medical, family, and social history and medication list was compiled upon hospital admission. As the pharmacist on the Transitions of Care team, you take a moment to review these.